All right, go ahead and start. And if you want to start by giving an introduction of yourself, we can go from there and then go right ahead.
Sounds good. Hi, my name is Ephraim Parent. I'm an associate professor of radiology at Mayo Clinic, Florida. Nuclear radiology is my specialty with imaging and therapeutics. And today I'm going to be giving a short lecture on updates on our PSMA PET and targeted radionuclide therapy that we're rolling out for metastatic prostate cancer. So overview, learning injections, we're going to first talk about a little bit about the disease itself, talk about PET, which is our imaging technique to be able to look at the molecular function of this. And then we're going to talk about the therapy aspects of this and how this applies for widespread applications across the nation. So prostate cancer, this is a little bit of a cartoon, just showing kind of time course, time on the bottom, and then kind of how much disease is along the y-axis. And initially, when prostate cancer starts, it starts in the prostate gland, it's confined to that. And at some point, the PSA values are going to go up and the patients will be diagnosed with prostate cancer. And at that point, there'll be some kind of definitive therapy. It could be radiation therapy, brachytherapy, or surgery. And at that point, the PSA is going to drop down and the patients will go into remission. Inevitably, though, unless the prostate was completely removed, there's going to be an increase in PSA and the disease is going to be growing again. And this is what we refer to as biochemical recurrence. And this is when imaging will take place to kind of see if we can localize disease or where it's spread to. And then there'll be some form of kind of secondary therapy, salvage radiation therapy, external beam radiation therapy, hormonal therapy. And at that point, again, the PSA is going to drop down because the tumor is going to respond to that therapy. And it'll be quiescent for a period of time, but then it's going to start going up over time. And this is where you get into this castrate-resistant prostate cancer, which is the most common form of what we see when I am seeing patients is in this form. And this is where basically the hormonal therapy hasn't worked, the local therapy hasn't worked, and it's now kind of spread out beyond. And there's now other therapies that we can, that your oncologists or your radiation oncologist can do. Hormonal therapy is a common form. There's newer drugs on board like enzalutamide. Chemotherapy with docetaxel. There's different forms of immunotherapy coming on. Today, I'm going to be talking about the nuclear options. There is radium or Xofigo. I'm not going to be talking about that today. I'm going to be talking mainly about PSMA, targeted radiotherapy. And this is where it's kind of going on. And this is, kind of this battle that we're facing, where we, at this point, really with castrate-resistant prostate cancer, we don't have anything that's curative. We're basically just trying to knock it down and get a good quality of life for the patient where it doesn't necessarily interfere with them. But we don't really have a way to cure prostate cancer at this point. So, people might have heard a lot about PSMA. Well, what is that? Why do we care about that? So PSMA stands for prostate-specific membrane antigen. This is a protein that's along the cell surface of prostate cancer cells, prostate itself, and a lot of other normal tissues. We don't really care about the function of this. It's a metallopeptidase. All we care is that it is expressed at very high levels of prostate cancer, 90 to 100%. The most common form of prostate cancer that does not express is neuroendocrine prostate cancer. So if that's the case, if someone has neuroendocrine prostate cancer, PSMA therapy and imaging is not really an option. And then you'd be going towards more systemic chemotherapies. But what we do see, again, excluding the neuroendocrine tumor, is that PSMA expression increases with the higher grading, which is kind of opposite of what we sometimes see with other forms of targeted imaging and therapy, such like with neuroendocrine tumors, where those higher grade tumors actually express less of their somatostatin, which is what we image for those. We do know that this PSMA agent, or not agent, this PSMA molecule is found in the neovasculature of a lot of different malignancies, such as glioblastoma. So it's not just for prostate cancer, but it can be used for imaging and potentially therapy for a whole host of different malignancies. Overall, what we care about for PSMA is that we can target it. And then if we have a drug or a radionuclide therapeutic in the case for what we're talking about today. Once we bind to that, it gets internalized inside the cell, and then we can deliver the payload of either a chemotherapeutic or a radiotherapy drug, like what we're going to be talking about later on. So there are several different small molecules that have been made. This is just a sample of them for prostate cancer targeting the PSMA molecule. And we're not going to really get into the chemistry at all today, but basically they have these urea core, which is this kind of little moiety with a ketone and two amino side chains. And those are kind of basically all our PSMA targets have this moiety. And that's what's binding to the PSMA. And then you have this linker, and it's usually then tied to a cage or some kind of tether to have a radioactive isotope in it. And the changes of imaging and therapy are all about how well it binds to the receptor and how well it gets internalized. And this is just some data, but basically people can measure when we're looking at these, the most effective molecular or radioactive agent that can get internalized into the cell, because that's going to help us to image and then treat the prostate cancer. There are 2 agents right now that are FDA approved for PET imaging, which stands for, I guess I didn't ever define it, as positron emission tomography, which is our kind of common molecular imaging technique that we use. And this PSMA 11 and Locomets is the Novartis trade name for this. And then this DCF-PYL is also known as Polarify. Those are both PSMA avid FDA approved agents for PET imaging. There is this PSMA 617. Here is the FDA approved agent Pluvicto for PSMA targeted therapy. So those are the 3 agents right now in this country that are FDA approved for imaging. There's a whole host of others that I'm not going to really be talking about today for looking at potential imaging and therapeutics as well. Overall, if people might have a question like, well, which PSMA agent is the best one for me to be looking at for my prostate cancer? There's not really a clear winner. It's kind of, I give the analogy of like vanilla. I can go to the grocery store and I can, I want vanilla ice cream. Well, there's French vanilla, there's vanilla beans, there's natural vanilla. There's all these different vanillas. Well, they're all vanilla. Yes, there's slightly differences, and maybe you like one more than another, but it's not like there's one that's best. Some of them have a little bit more excretion in the kidney and bladder. Some have maybe more parotid gland uptake. But ultimately, I would say wherever you're at for your local, whatever your local imaging center is able to provide is going to be fine. It should be noted that technically for Pluvicto therapy, it requires the PSMA 11 PET agent, Locomets, but the NCNN guidelines also allow for Polarify. So that's something that you could discuss with your provider if you're worried about which PSMA PET agent you're being imaged with and how that may affect reimbursement for therapy down the road. Overall, the accuracy of these is very good compared to other molecular imaging agents. And those also were better than other conventional imaging agents. So, recently in like 2016, we had fluciclovine, which is an amino acid that is still on the market and can be used for prostate cancer. Choline has also been used. And those are all better than standard imaging techniques such as CT or MRI to detect metastatic disease. And I don't really want to get into the weeds of like how we interpret these things, because that's not really the point of this. But understand that as even with PSMA and like these other things, there's not a 100% accuracy with this stuff. Meaning that I like this study, and this is what I'm highlighting, is rather than kind of just going off the imaging findings, they actually correlated the imaging findings with lesions that were taken out and known to be true disease or false disease. And these were at 3 sites: University of Michigan, UCLA, and UCSF. And they found that basically this threshold using SUV of about 7.5 gave the best differentiation benign from malignant findings. There's a lot of clinical interpretations out there using it to liver and other things like that. So overall, understand that while we are better for identifying disease, it is not yet perfect. And maybe 10 or 20 years from now, we'll have another agent out there. But right now, we are able to identify the vast majority of disease, and it does a pretty good job for it. There is some difficulty, specifically, I would say, in the prostate bed. So if patients still have the prostate intact, there's a lot of false positives that you can see in the prostate bed. And that there's always that imaging is a good estimate of what is real, but if there's ever a question, that's why we may require or recommend getting some pathology sample if that's going to change management for the patients, because it's not 100% certain. There's other things that can show up high on PSMA, or maybe we can miss something. So really, there's no yet substitute for tissue pathology. Comparing to other studies out there, other agents out there, it's like fluciclovine I mentioned earlier, which is an amino acid. PSMA overall does better, especially in patients that have low PSA values, like if it's like less than 1. PSMA is probably going to be able to do a better job of detecting that oligometastatic disease, but it's not like a night and day difference. It's more of we're on a continuum. Like if all someone has available is a fluciclovine PET to be able to evaluate the prostate cancer, I would say go ahead and do that. That's just fine. However, if someone is wanting to get the Pluvicto or the PSMA therapy, they would require a PSMA PET scan. A fluciclovine scan is not a substitute for that. I'm going to transition a little bit here to, instead of just talking about the imaging, to talking about a little bit of the messiness in this. And I think it's important to have people understand, because for prostate cancer, there's a lot of different hormonal and other factors that are going into play. And as most patients that are being considered for either molecular imaging or therapy are on hormonal therapy, and in fact, it's a requirement for Pluvicto, that I think it bodes, it's worth talking about it, because patients sometimes may have a question as whether I should come off my hormonal therapy or not. And the short answer is no, you should not. But let's talk about it a little bit. So this is like a prostate cancer cell, and this T represents testosterone, which is an androgen that's in men, actually in both men and women, predominantly more in men. However, it gets internalized in the prostate cancer cell. It gets converted to a molecule called dihydrotestosterone. This then binds to the androgen receptor, and then that androgen receptor then goes into the nucleus and turns on genes and causes it to get bigger and grow. And so this is this axis that we're trying to stop when we put people on hormonal therapy. We're trying to stop these genes from being turned on to stop it from growing. We do know that a downstream effect, meaning that one of the effects of the androgen receptor is this increase of a molecule called prostate-specific antigen, which I've talked about previously, but that's a way that we can get blood values and get a sense of how much prostate cancer is out there. People have tried imaging the androgen receptor. Let's just say it doesn't really work too well, mainly because the specificity or not all, there's a heterogeneous nature to prostate cancer, and so not all prostate cancers will have uptake. And also, when we treat people with anti-androgens, we're blocking that axis, so it doesn't really work too well. But what we do know is that the PSMA itself, that protein that we're imaging with either and we're targeting for therapy, it is also a downstream effect. It's affected by the androgen receptor. But unlike PSA or the prostate-specific antigen, I understand that all these terms kind of sound similar. It actually is decreased. So in patients that have stimulation of the androgen receptor, meaning that like testosterone is binding to the androgen receptor and things are going forward, you actually decrease the level of PSMA uptake. Conversely, if you block the androgen with like anti-androgens or letrozole or things like that, then you will actually increase the level of PSMA, sorry. And so it's due to this gene that's being turned on or turned off by the androgen receptor. So again, the androgen is going to downregulate this gene and suppress PSMA expression. And when you turn off that, you can actually increase the PSMA uptake. So what does that mean for overall what we want to say? Let's get back into now the downstream effect of what we're talking about as a patient. Well, we do know, and here's a case report of a patient at UCSF that was imaged before they got stuck on hormonal therapy. Then they stuck them on hormonal therapy, meaning they're stopping the androgen receptor. And you can see all these lesions that are now more evident or showing up on the PSMA scan that were not evident before. And in fact, all of these things lit up. And so what the overall, the point is that if anything, for the most part, if especially in the short term, if patients are put on hormonal therapy, the PSMA PET scan is going to detect more lesions. Now, it's a little bit confusing because there's also data out there that shows that if people are on hormonal therapy or anti-androgen therapy for a long period of time, actually that the anti-proliferative effect of the androgen axis blockade will actually overcome whatever PSMA expression we'll see. So sometimes if patients are on long-term therapy, we will actually see less PSMA uptake. Overall, and I don't want to confuse patients, but I'm just trying to say this is still something that's a little bit that we need to figure out over time. We need to get more data about the timing of these things. But what do patients need to know? One is if you're not on hormonal therapy and you're looking for like initial staging, go ahead and get the PSMA PET. However, if you are on androgen deprivation therapy or something else, stay on it. Short-term effects may increase it. But there's also these things that like changes may imply that there's worsening progression of disease pre and post. And I don't really want to get into that a whole lot because it starts getting into the weeds. And I think it's a little bit above kind of where this audience is worried about. Ultimately, again, what I'm going to say is that go ahead, whatever androgen blockade or stimulation that you're on as a patient, go ahead and get it wherever you're at, and don't worry about the timing of that, and let the imaging team worry about how that may be affecting the clinical read. Let's move on because we're kind of running out of time. I want to talk about the therapy now. So we've talked about the PET imaging, and the nice thing about with molecular imaging is these are the same molecules that we can image with. We can actually then switch out the isotope from an imaging isotope that gives off light that our cameras can see to an isotope that gives off radiation in the terms of particulate radiation, such as beta particles or alpha particles that can give selective therapeutic radiation to the prostate cancer. And so this is a patient here that had the PET scan, and you can see this is now doing imaging with the therapeutic agent showing that we're delivering selective radiation. That's those same areas of disease that lit up on the PET scan. And again, how is this all working? Well, we have our PSMA molecule that's binding to the receptor, and then it's being internalized. And so the PSMA molecule that's FDA approved for therapy has a lutetium-177, and that gives off beta particles, and that's causing DNA damage. And that's effectively how this therapy is being effective. The indications are basically you need to have PSMA uptake on your PET scan. So you need to have a PET scan beforehand. And you also want to not have disease that is discordant with PSMA. And I'm going to talk about what I mean. So we do know that there's a large minority of patients that have metastatic castrate-resistant prostate cancer. And maybe they have PSMA-avid lesions, but they'll also have some lesions that are hot on FDG, which is a agent that we use to look for glycolytic index. And we do know that if patients have disease that is avid on FDG, but not PSMA, then they will have a worse outcome. So this is an example from the literature. So this person here has an inguinal node on FDG that's hot, but not PSMA hot. So if this person had undergone PSMA therapy, you would expect this to not be effective. Conversely, this person over here has a inguinal external iliac lymph node that does not have increased FDG uptake, but does have PSMA uptake. And so you'd want to treat this patient. And so a lot of times when we're looking at the PSMA and trying to evaluate which patients are appropriate for therapy, we're looking for this discordant disease because we don't want to have patients go into therapy where it's not going to be effective. And just kind of talking about some of the data outcomes for this. So this is a paper where they looked at around 50 patients that had PSMA negative but FDG positive disease, this discordant hypermetabolic disease. And they progressed much faster after therapy with an overall survival of 2.6 months compared to 13.5 months. That's a really dramatic difference, especially with oncology. And so we look at this. And so this is another study that looked at the same thing with patients that actually were treated with PSMA therapy that had discordant hypermetabolic disease. Again, this is just another example of a patient that had FDG uptake, but nothing on the PSMA PET. And they found that patients that, even though they'll receive therapy, they had a much shorter progression to disease. The only real difference is they had maybe fewer cycles of disease, but the overall survivability, again, was 6 months compared to 11 months. So if we as imaging or oncologists tell somebody that they're not really candidates for PSMA therapy, I understand that's very frustrating, but it's ultimately saving patients time and money from being expended on a therapy that's not going to be working for them. If we're going to be doing this therapy, we want all our lesions that have prostate cancer to be having PSMA uptake. Otherwise, we just know there's too much data out there that says this is not going to be effective. So in summary, this person with PSMA PET, a lot of disease, very little FDG, some concordant disease, so they'd be a good candidate for PSMA therapy. Conversely, this person, a lot of skeletal disease on FDG PET, nothing on PSMA, they would not be suitable for PSMA therapy. So imaging is a very critical tool in addition to looking at all the lab values and everything else to understand if a patient is suitable for therapy. We don't really care if patients develop this discordant disease after we start therapy. The outcomes aren't really that different. So really, if someone's asked to be doing an FDG PET or even maybe a fluciclovine or choline PET to make sure there's no discordant disease, it's really before that initial therapy. It's not something that we'd worry about afterwards. So let's talk about the therapy. Why is this so good? So there's two big trials, the therapy and the vision trial. And the therapy trial was a phase 2 trial, had 200 patients, and they compared our Pluvicto or our PSMA therapeutic agent to paclitaxel, and they found that there is a much improved outcome or PSA response to that. Now, this therapy, this trial actually did include FDG imaging as well to make sure that there is no discordant disease. And the outcomes you can see here, this response to PSMA on the cabazitaxel, there's a 37% compared to 66%. So patients did much better on this compared to standard of care therapy. It should be noted that early on, there wasn't really a difference, but it's that long-term difference in disease where they show that there's a very strong difference of improved therapeutic response on the PSMA 617. The vision trial you may have heard on, this was a very large study. Very similar, they had 200 millicuries of therapy 6 weeks apart. And they also wanted to make sure that there was no PSMA negative disease. And they had 800 patients enrolled. That's all that's now FDA approved. Again, very good results compared to standard of care therapy. For the sake of time, I'm going to kind of skip through some of this, but ultimately just understand that we want to have patients having a PSMA PET, and actually the FDA requires it as well if we want to get reimbursed for it, to just make sure that therapy is going to be effective. I'm going to talk about really quickly, I'm going to skip through some of this for the sake of time, to talk about kind of what to expect on the day of therapy. So first of all, contraindications. We do want patients to be living at least 6 months, because that's how long the therapy basically is going for. And if patients are not going to last that long, this is not going to be effective. Understand, again, this isn't a curative therapy. This is something that's going to be improving quality of life and prolonging life, but it's not going to be curing it. So if patients aren't going to be living, if they're on death's door, unfortunately, this is just not a fair therapy that's going to be effective for that. We do worry about urinary obstruction because it's excreted in the urinary system. If there's other radiation risk where the patient has, we want to make sure that their liver function, bone marrow is functioning well. If there's something else acute, we need to take care of that first. We bring the patients in, we talk to them, go over everything else, and usually these are referred to from urology, radiation oncology, or oncologists, and we get consent for them to get therapy. The whole therapy itself is about 3 to 4 hours. We will add lines, IV for giving the drug and fluids. We don't do this anymore. There's early on this ice packs. This is not really something that is done much anymore. We found this was not really effective. But otherwise, it's pretty simple. We get the IV lines going. We do look at the dosing, but for intents and purposes, we have found that this is actually very within the dose limit safety for all the major organs. We do recommend that avoid contact for 2 to 3 days for young people, especially pediatric populations. Avoid close contact to pregnant women. As children are younger, they're more sensitive to radiation therapy. Wash hands, do good hygiene. You want to remove the radiation from you as it's excreted in the bodily fluids. And basically, for about a week or so is when you're going to be shedding the radiation. And after that, if there's a little bit still left in there, it's not really much of a concern. Side effects are usually very mild. They don't last very long. There is some anemia that we look at, and so that's why we'll keep getting lab values after every cycle to make sure that there's no long-term toxicity. There is some uptake in the salivary glands and the parotid glands, and so we want to make sure that nothing is affected there. And so these are things that the clinicians and the nuclear radiology team will be asking the patients in between therapies. I kind of talked about this already. So during the actual administration, we want to hydrate patients. We'll have them drink, and that's we don't necessarily need to be doing IV hydration, but oral hydration is very good. The injection only lasts about a minute itself. You can give fluids IV if that's the best way, but we don't typically do it. We're not too worried about diuretics or laxatives. These are things that we don't really worry about, but maybe depending on the initial the presentation of that individual patient, that may be effective. Same with antiemetics, meaning anti-nausea drugs. We find that patients have much less nausea with this, unless somebody's already predisposed to this. We don't typically do it up front, but it is something that we can add as worried. As I mentioned, we don't really do salivary gland ice packs anymore. That's something that was concerned earlier on, but now it's not such a concern. And the standard therapy is 6 cycles every 6 weeks apart. We might do scans afterwards, and that's going to be depending on the individual condition and the individual imaging center that you're at. And then we will be following up labs afterwards to make sure that everything is doing well. This whole body imaging with the therapy, we can do it to show that we had uptake in the prostate cancer itself, but again, it'll be dependent upon the individual institution that you're at. And PSMA PET imaging can be done. Typically, it'll be after therapy to see how the disease responded, but there's not any set schedule of events, and it's really up to the individual clinician and the practice as to how they'll be following you. Questions still remain. How much? We're giving 200 millicurie because it's easy, but it's something that maybe to be increasing the amount of radiation will be more effective. Immunotherapy, combination therapies, we still need to have a better sense about that. Can we improve effectiveness by having patients be treated earlier, and maybe be treating very upfront? And there's also agents such as those that are give alpha that are coming on board, and maybe those will be better as well. Summary. So we have our PET agents approved. These are requirements for PSMA therapy, and we need to make sure we rule out discordant hypermetabolic disease. The therapy is effective. We have good outcomes. We're not there yet, and there's a lot of studies on board that are currently ongoing to be looking at how to include this with other types of therapy as well. And I'd like to thank these people for some of their slides and for your attention. Thank you very much.